Okay, welcome to Conjunctival Mysteries for Class 2020. We are so thrilled to be here today. I am Melissa Barnett and I have Tom Arnold. And thank you for listening to this lecture, and I hope that you're enjoying the meeting so far. We're very fortunate to work with many companies to grow our wonderful profession. First, let's talk about lumps and bumps. So there are various things that occur on the conjunctiva, and once you start fitting scleral lenses, it seems like everyone has a pinguecula or a pterygium or a glaucoma drainage device, and we need to vault or go over these areas to have a well-fitting lens. We don't want to see any signs of inflammation. We want the eyes to be white and quiet and not red. And we want to vault over these elevations and not necessarily push on them. And especially for patients who have disease such as glaucoma and have had glaucoma surgery, we want to make sure that we're not interfering with their lens fit and potentially increasing their intraocular pressure. Traditional forms of getting away from these irregularities are notching. So here you can see an image of a notch, which still can be an option for patients that have, say, an elevated pinguecula or pterygium. This patient on the right is wearing a 15.4 millimeter lens. She has glaucoma, and with a notch, it was able to just get out of the way of the elevation. Focal vaulting refers to an elevation that can be at the edge of the lens or within a lens, and it's a hemispheric ripple that's created at the lens landing zone, and it maintains the circular shape of the lens. This can vault over anything that's elevated, such as a Salzmann's nodule or pinguecula or pterygium. I find that it's helpful to tell my patients that we are vaulting over whatever it might be for a few reasons. One, that the lens is intact, so it's not damaged or anything like that. And number two, for when the lens is being put on and taken off for application and removal, it's important to orient it specifically. So for example, if there's a nasal pterygium, it's important to have the point right there nasally, and it's helpful to tell staff as well to train the patient to insert it correctly. So one example is microvault technology. So this is with the Zen lens, and here you can see these beautiful images of the part in the lens. This is the area of the microvault that is vaulting over the peripheral pinguecula in this case, and here you can see the compression up top there. Edge vault is by valley contacts. This is another method of elevation and going over those areas. And here you can see some beautiful images of the edge vault within the valley contacts lenses.
Yes, and different labs, as Melissa has pointed out, have different ways of dealing with this. One entry into the market now is something called control peripheral recess from Blanchard contacts, or CPR technology. And as in the earlier illustrations, it creates, an elevation specific to the pinguecula or bleb or whatever we're trying to get over. And so you can see that I'm from Houston, Texas, and everybody knows the famous quote from the astronauts, "Houston, we have a problem." So you can have a well-fit lens, a comfortable lens, but maybe digging into that elevated area as we see here. And one thing that we should always do in our follow-ups with patients, whether or not they have a specific complaint or not, is always remove the lens and examine the surface of the eye. And here you can see the fluorescein illustrates that edge is digging in a little bit to these pinguecula in both eyes. So you can have good comfort and the eyes are no longer dry, as this patient says, but you can see that she does have a chief complaint still that, yes, but at the end of the day, my eyes get red, especially in the corners. And now we can see why right here. So fluorescein is a good indicator. And as Melissa was just pointing out, what we used to do for tube shunts and elevated areas here is take these deep notches, into the edge of the lens. As we see here in this elevated tube shunt. But the problem with this is that when you just simply cut the edge out or notch it, you're left with getting into the thick inner part of the lens. So this can allow bubbles in, allow air in, and just flat be uncomfortable. And so in this illustration, again, the Blanchard system is you can go online and actually calculate and enter the values necessary to get over this area. You select the lens, you note any rotation in the haptic, and you identify how large the recess should be, how deep, how wide, how tall. And you can enter that right into their system online, and that goes right into the manufacturer of the lens and will be replicated even in subsequent lenses. And so you can see that this previous patient came out really, really well. Here's the pinguecula over the left eye, and notice it's not a notch. It's just simply a vaulted area that is manufactured directly into the lens haptic. And the right eye came out very, very well as well. So this is very comfortable for the patient. The eyes are no longer red. And here in Texas, where I am, where there's so much sun, this is a very, very common issue that we have with our patients.
And the same thing in California too.
You guys love sun out there, I know.
Yeah. And, patients all the time come in with pterygium when they just grew up in California and spent a lot of time outdoors. So sometimes we need to go a little bit more specific for these patients. And iPrint Pro is an impression-based technology that matches the exact contours of the eye, so within 2 microns. So it's incredibly precise. So an impression is made of the eye, and it's not painful or anything like that. And I find that I tend to get a little bit more messy than my patients with this blue goo. But here you can see myself. So that's my eye. At the bottom left, that's an impression that was made. And I find it to be really incredible how precise we can make these lenses. So for example, my patients that have really large blebs where a notch or a peripheral elevation is not going to do it, iPrint's an option. And another option are those who have really protruding grafts, or those that just want a very quick fit. I have lots of patients, and Tom, I'm sure you do too, that come from a distance, and they can't be coming back multiple times. And so creating a very specific lens for them has helped save time as well.
Whether you're helping your patients with the daily irritation of dry eyes or combating other ocular surface diseases, Boston Sight Scleral has the data-backed science and experience to help them see the world through a whole new lens.
So here you can see up close the iPrint, and that's the goo that I'm referring to. And it's incredibly specific. Here you can see just this beautiful impression. And I do take images of my impressions to make sure that they are correct. And images, I mean pictures of the impressions to confirm that the impression is a good impression, because it is important. And sometimes multiple impressions will need to be made. Tom, I believe you have some scanning technology.
We do. This is extremely helpful. We used to have to take our molds that we just saw there, Melissa, and send them, via FedEx, to the lab in Denver, Colorado. And now we actually have our own scanning device so we can scan that image and upload that data directly up into the lab. So it saves us 2 days. And as you said, especially with iPrint, patients often come from far away. And so time is very important to them. So it's great. We've really taken this to the next level.
Definitely. And here you can see the setup and these beautiful lenses. And the really interesting thing that we've discovered, and I'm sure you have too, Tom, is that patients' eyes, yes, they're irregular, but they also have all sorts of lumps and bumps, not only on the cornea, but also on the scleral conjunctiva. So each eye is very unique. So same thing, informing the patient that this is a very specialized lens, this is how to orient it, how to put it on, but it can get some really great results. A white and quiet eye, very comfortable lenses. And there are many specific things that can be done and very helpful for any sort of elevation. It is possible to include multifocal and prism and all that fun stuff as well. See all these beautiful images there. So sometimes a scleral lens is not an option. We've talked a lot about scleral lenses and the potential increase in intraocular pressure. Anyone who has corneal endothelial changes where perhaps a scleral lens is not an option, or someone who has a very delicate corneal transplant, perhaps a corneal gas permeable lens would be a better option. And we use those commonly in our practices. So here's just an example with an impression-based lens. It can be a corneal gas permeable lens as well. And these lenses, both corneal GPs and scleral, are not perfectly round. So they could be more larger horizontally than vertically, so more sort of egg-shaped or ovate.
I'm really excited about that technology because we can't forget about the corneal RGPs. They definitely have a place, and I enjoy employing them whenever I can. So, yeah, got to keep a lot of tools in our toolbox for our patients. Well, here's a case I think is very typical, will resonate with a lot of you. Is a gentleman who came to us with what I would call moderate keratoconus. He was 39 years old, but as we can see, diagnosed quite late. He's a salesman, he travels, drives, and he came to us from Beaumont, Texas, which is about 120 miles away from us. He was wearing soft contacts, and his chief complaint was he had never seen well and was just recently diagnosed by an optometrist that I know who referred him to our clinic. So we all take topography, and obviously we can look at it and see that this gentleman certainly does have keratoconus. And what kind of caught my eye at first is it looks like the left eye is worse, doesn't it? It's a larger area of ectasia. It's low, it's decentered. But when we look at the spectacle RX, we can see indeed it's the right eye that seems to be a bit worse, at least from an acuity standpoint. And we do a pentacam study, which is using the Scheimpflug camera. We get the rear elevation of the cornea as well as the the anterior surface of the front elevation. And you can see that his Kmax is indeed worse in the right eye than the left, and his cornea is thinner. But what I want to point out in these elevation maps of front and rear elevation between the eyes is that look how much more ectatic or elevated both the anterior and posterior surface of the cornea is in the right eye. And that explains his very high amount of myopia and distortion. So it's very important, if we have the tools, to look at the back surface of the cornea as well in these patients.
Oh, definitely, especially if you're not getting the vision that you expect with a lens, looking at that posterior elevation is really helpful.
And in early keratoconus, as I'm sure you had discovered, Melissa, is that you can have a fairly regular anterior surface and the distortion's all in the posterior surface. And that's where you get the scissoring reflex, retinoscopy and so forth.
That's why retinoscopy is so important.
Mm. And so it's very important, I think, for scleral lens fitters to start learning to interpret and use the elevation maps, because that's what we're trying to do. We're trying to get over these surface ectasias or elevations. And one tip I'd like to share is that when you have an alignment of the front and posterior elevations, if they're basically in the same axial plane, so to speak, then even with a very ectatic eye, you can expect pretty good vision, as we see here. As abnormal or ectatic as this eye is, these eyes are, you can see that the elevation maximums are fairly lined up along the same axis. Then here you see a more severe case where this is a different patient, and you can see that the back surface is so distorted. You have to be careful about promising, a certain visual acuity. You may not have it in a case like this. And so where we get this posterior mapping technology is with a pentacam, a common device. There's several others. Zymer makes something, Galilei, and so forth. But the point is we have Scheimpflug cameras that image both the front and back surface of the eye. So continuing with our patient here, we actually fit him last year, and he was doing quite well, but he felt like lately the left eye was not as comfortable. Here we see the parameters of the lens, a 16.0 diameter, very, very typical with the toric haptic. But looking at him at the slit lamp and listening to his complaints, we could see that left eye was riding a little bit low, and he was experiencing an abrasion on the superior part of his cornea. So again, following my own advice, we took the lens off and stained him, and you could see where it was impinging a little bit on the landing there and had that superior abrasion. So this is what we tried to address. And so why does this happen? Why do scleral lenses always seem to decenter? Why does this happen to me? Well, it's because of what we all remember, of course, from ocular anatomy, the spiral to low. And that's just the fact that the extraocular muscles do not insert at the same distance from the limbus. Not only do they not insert in the same place, but the elevation of the sclera in these areas is different.
Miro 1 month delivers one of the highest levels of oxygen transmission. Available in sphere, toric, and multifocal. Miro 1 month contact lenses from Menicon.
And so studies were shown that in this particular sampling of 140 scleral patients, up to 60% of them, 66%, were ectatic and showed no regularity at all between the sclera. So 66% highly irregular. And this was from a paper in 2017 by Greg Denier and his team. Very, very good paper, and I'd recommend it to all of you. And so one way of attacking this is, or addressing it is, we want to try to recenter that lens. So it was obviously abrading him, so I wanted to increase the sagittal clearance just about 50 microns, but I wanted to increase the toricity a little bit to 275 microns. Now, one tip here is that your lens, no matter what the overall diameter of the lens you pick is, it doesn't land at that overall diameter. It lands at something less. And that is called the functional primary scleral distance, okay, or the depth. And that's an important feature to know. And in this calculator, online calculator that we have from this particular lab, it gives us the primary functional scleral depth of this particular lens. It's a 16 millimeter diameter, but it lands at 13.9 millimeters. And so this term comes from a paper from last year, an excellent paper, by Langis Machad, Mike Lipson, Elise Kramer, and Maria Walker in the BCLA journal that sought to simplify and define common terms that we use in scleral lenses so that we're all speaking the same language. All of us know the various labs have different terms for how they measure central clearance, limbo clearance, and the landing zone. So this paper, really a landmark paper, sought to solidify and simplify all these terms. And that's where we get the PFSD term from. And so he made these changes and got a better fit for this gentleman, as we can see from these fluid reservoir pictures. So we have a nice fitting lens now, and no impingement, and the eye's much wider and quieter. And I'll show you how we did that. So his final sag came up a little bit. I increased his toricity, as I said, to 275 microns. And this is an important thing because you'll notice in this prescription, he also has an astigmatism correction, a cylinder correction. And increasing the toricity in the haptic oftentimes will help stabilize that. So another question that comes up, we see our patients and we go, oh, they have keratoconus. Oh, or is this pellucid marginal degeneration? We see maps like these, and I learned in my training, and maybe Melissa, you did too, that when we saw the kissing doves or the lobster claw or the crab claw, that indicated something called pellucid. But that's not the definition of pellucid marginal degeneration. Christine Sent and I, who invented the eye print that Melissa was talking about earlier, wrote a paper last year differentiating these two entities. And so Michael Bellin, who did a lot of work with Oculus and the Pentacam, wrote that these asymmetric curvature patterns can happen in a normal cornea when the apex, the line of sight, and the measurement axis don't line up. That's a normal variant. And so PMD is often misdiagnosed. And it's misdiagnosed also because if you use a smaller pellucid-based topographer, you're not getting far enough out to see the actual the elevation of the cornea, and you're not taking pachymetric data. You're not taking corneal thickness data, which would really identify what pellucid is. So pellucid is truly a thinning of the inferior cornea, a band of thinning 1 to 2 millimeters in from the limbus. And you don't see that in a placido-based system. And here in this map, it's a global pachymetry map. So you can see that band of thinness lies below the apex of the cornea. And that truly is pellucid marginal degeneration. And actually, it's quite rare. How many cases have you seen, Melissa, in your practice, do you think? I only have a couple.
Well, it does depend on the definition, right? I do have a few, though, and I find going very specific in the lens design, I tend to go a little bit smaller in these patients than I normally do to tuck under that inferior area. What about you, Tom?
Yeah, same thing. There's certain designs that are asymmetric in that area to tuck in, just as you said, both corneal and sclerals. And so these are maps of both eyes, and you can see that even though he has very pronounced so-called kissing doves, he doesn't have that band of thinning that would define solution. That's pellucid. Yeah. Okay, and I have one more case here where you can have a normal cornea, so to speak, but they still benefit from scleral technology. So this is a 39-year-old woman. Also, she was referred for a scleral evaluation because she had a scar from a previous ulceration. She also had dry eyes, lived down the South Texas coast, which is very windy, and she was a smoker. So she has all the factors going for her that would make her vision and eye uncomfortable. So you can see that she has that ectatic area, that lower area down inferiorly temporally. And you can see that she's correctable to 20/20, but has a high degree of asymmetry or irregular astigmatism. So our HVID is normal, which is a very important diagnostic tool. You always want to know what the HVID is when you select a lens. And so we designed this lens with another technique of scleral profilometry, which I call fitting by the numbers. And so, it is very important to know what the HVID is, and sometimes the vertical iris diameter as well. In this instrument, the Pentacam, they call it horizontal white to white. But 11.6 millimeters is a very average eye. And so I'm going to pick a very average overall diameter of my lens of 15.6. And so in the calculator for this particular scanner, the CSP from Pentacam, we want to know where that lens lands. It's a 15.6 lens overall diameter, but it's landing at 13.6. And so that means the sagittal depth of that lens, is the height of that cornea, is going to be 33.55. So we build in a fudge factor, if you will, of 300 microns of clearance because we don't want to rest on the cornea. And so we're looking for a lens of 3,655 microns of depth. So we put that number into our calculator for this particular lens. And I picked a 15.6 because I said it's normal, and a vault of 4,600 or central clearance 4,600 is a very average clearance. So we calculate, and from that we get the resultant primary functional scleral depth, and that comes out to be 38.20. Now we only needed 36 or 36.55, so now we're about 165 microns too much. So let's go back to our calculator. Let's drop it by 150. Let's apply our over refraction, which we've done through the first lens, and we calculate again. Now our primary functional scleral depth is 36.70. So we're right on the money. So this is the lens that we're going to order, and she did very, very well with that. So in this way, we can use tools offered by these labs to simplify and fine-tune our fitting. And I hope everyone will explore some of these options and take advantage of them.
Those are great cases, Tom. And sometimes people don't have all this great technology. And so we do diagnostic fitting. And there are some new guidelines as far as in-office disinfection for diagnostic lenses published just a few months ago. So here's a different patient he presented to me. So he's protruding graft number 1. I kind of name my patients. I also have protruding graft number 2, which is a different patient. But he was a 60-year-old male. He was referred to me because he was wearing some corneal GP lenses and the lens dislodged or came off of his eye. He was fit elsewhere with scleral lenses, but was not successful because all lenses were touching. And just of interest, his father also had a history of keratoconus and wore scleral lenses in the 1950s.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
So he presented a pretty poor vision, very irregular astigmatism with steep corneal curvatures. He had thicker central corneal clearance of 620 on the right, and a little thinner on the left, 522. So I did want to obtain an endothelial cell count to make sure that his eyes could tolerate the scleral lens. And those were adequate in each eye, always checking pressures. And in this example, his HVID was 12, so a little bit larger there. And he had quite protruding grafts, as you could see in that first picture. He did have some signs of cataracts as well, meibomian gland dysfunction, which I addressed by using eyelid cleaner and compresses, omegas, artificial tears. And I talked about different scleral lens options. So Here you can see his thick protruding graft. So in this case, I used a lens design that is specified for both the right and left eye, so different lenses for each eye. Since his corneal curvatures were so incredibly steep, I wanted to start with a steep lens. Here you can see with the red circle. However, this lens touched his cornea, and we don't want scleral lenses to touch at all. So with minus 150, I was able to get him to 20/20 minus 2. However, I know that a lens touching the cornea, it's a little bit difficult to determine how much it's touching the cornea. And so for the left eye, same thing, went to the steep sag. The lens touched the cornea as well. So I said, okay, let's order some lenses and see what happens. So I ordered new lenses with an increase of 400 microns in each eye, and all lenses still touched the cornea. So then I ordered another set of lenses with 800 microns more sagittal depth for each lens compared to those original lenses in the diagnostic fitting set. And fortunately cleared the cornea. So here you can see the lens cleared the entire cornea without touch. Whenever this happens, I cheer. I don't know about you, Tom, but if I'm really trying to clear that cornea, I'm like, I cleared the cornea.
Absolutely.
Also obtained 20/20 vision. Left eye, kind of same story. Cleared the cornea, 20/20 vision, and he's actually been doing quite well for even longer now. Now, the one thing that's happening with all these patients is they're developing cataracts and needing cataract surgery. So same situation with that patient. He's going to need cataract surgery shortly, and then which definitely affects the power of the lens and not usually the fit too much. There's a great new resource that I want to share with you from the Scleral Lens Society and the Dry Eye Shop. It goes over all sorts of different solutions, both application and disinfection, and additional solutions and cleaning solutions, and also just some key points like not to use water on lenses. And you can get this from either resource. And in the US, using specific solutions, these are some of the ones that we have. There's actually a new solution coming out soon. And in different countries, I know that we're all using something that's a little bit different. But for the preservative-free solutions, it is very important to make sure to dispose of them after a single use in order to prevent infection and inflammation. So all the cases of corneal infiltrates that I've seen have been due to reusing solutions. There is an upcoming study that's going to be looking at this, the adverse effects of scleral lenses on the cornea, specifically for microbial keratitis. And it's going to be interesting because in some countries, for example, solutions are not preservative free, and it'll be interesting to see if the rates of microbial keratitis are different in those countries compared to the US. So upcoming study. On the left here, you'll see a nebulizer solution. This is not an FDA approved solution. It can be obtained either from the pharmacy or online. And then on the right, there's Puralens, which is in a bottle that has to be disposed of within about 2 weeks' time. You'll see the neutrophil here. That's a unique solution. And Jenny Folk just published a really good paper demonstrating the benefits with this solution. It does not have any buffers, no preservatives. It does contain electrolytes, which makes it unique. It comes in 10 ml vials. And a box of 35. And then, of course, we have Lacquer-Pure, which is not buffered, Sclerophil, which is buffered, and the three in the middle are the FDA-approved solutions. Brian Tompkins came up with some really great simplification stickers for solutions. So keeping it straight with our patients is really critical. So his stickers say clean, store, and fill. And of course, we need to disinfect lenses every night to prevent infection. We want to make sure that we're not using using anything that is too abrasive. So here are some examples in the US of both hydrogen peroxide and multi-purpose solutions. Training and going over again and again how to apply and remove lenses is so important because scleral lens handling is the number one reason for scleral lens dropout. So there's a great video on YouTube on how to put on and take off lenses. Going over this with patients time and time again is so helpful. So if I'm fitting a new patient and I see them back, I always ask them, how's it going putting on and taking off the lenses? If they pause even for a moment, I make sure that we review handling in the office because I want to make sure they feel very comfortable with it. There are all sorts of helpers for our patients. So things like the C green lens inserter. So that's a light that is used, and the patient can use the inserter, the light alone, or with the stand. Here you can see both images at the bottom. A O-ring or an orthodontic ring can be used on the hand. There's also a ring inserter for the lenses, and my patients have been very, very creative. I'm sure yours have too, Tom. Using a styrofoam cup upside down with a plunger, using Play-Doh. The image you can see on the bottom right is a patient who developed his own device. There are all sorts of ways of doing it, or simply taking the plunger and having a white one and cutting a hole, or using a vented one where there's a hole at the bottom to allow light in is another helpful way to put on and take off lenses. So we really want to thank you for your time and your attention. We want to invite you to join us on our Global Eyes podcast to share the stories of those from around the world. And we look forward to seeing you in person next year.
Thank you for having us.